Awesome. Okay, so now let's see if I've learned how to change slides. Hey, wow. So again, we have no disclosures, although I have received some honoraria from industry groups, but nothing related to this presentation. So, I'm hoping that the cases we have tonight just help us all kind of continue to be open as we're seeing patients and doing the history and making sure that we're not sort of biasing our assessment by what we think might be going on. And I think that's kind of human nature, but I also think it's a bit of an art to be able to stand back and then do that synthesis as you go through. You're going to gather that information in the history. And then for many occasions, you're formulating what you think your differential diagnosis list is by the history. And then the other thing that comes up, and we're very lucky because of the nature of the clinic, is if we don't know, like tap on the shoulder, hey, I've got this person. What are your thoughts? If you had to see that person, what would you be thinking? What would be the first thing to come to mind? And, it's usually very busy and I have lots of learners and stuff like that, but I think they really appreciate time that they spend with the therapists of any discipline, really, because they appreciate that they often look at the body differently. So I think we can work really nicely and collaboratively. Takes a few minutes, but it's really cool when we can do that. So why do diagnostic dilemmas occur? Well, sometimes patients are just complicated, and how do we make sure that we're aware that there may be a diagnostic challenge that we're facing? And then what steps do we do to solve that? So, we make a diagnosis by taking the story. What's the narrative? What's the presenting complaint? What makes it better? What makes it worse? What have they tried? What hasn't worked? What has worked? Have they had it before? And so on. And there's a little bit of research and literature about how people make their decisions. And sometimes, and it's quite varied, actually. But the little bit of the literature that I was able to read, it was interesting that when asked, clinicians would make a decision about what they thought the diagnosis was at different stages in the storytelling. And then, of course, later after the physical examination. And then, often we get to the end of it all and we think it's A, B, or C. And do we feel compelled to tell the patient that it may be A, B, or C? Or do we feel committed and compelled to say, you definitely have torn your ACL or whatever? And is that appropriate, or is it better that we share with them that there may be some diagnostic uncertainty? All right, so let's jump in. And Ash is going to present our first case. This is the patient that he and I actually saw together. And it's pretty interesting.
Hi, everyone. My name is Ash. I'm the Chiro at Live Active. Thanks for joining in. I'm going to jump right into the case. I'm going to open the floor more for discussions. This is by no means meant to be more of a presentation, but rather than a discussion.
Yeah.
I try to look at the chat box, but if I miss anything, feel free to unmute and just ask the question as you wish. So this is a 55-year-old male that presented to me with left shoulder pain, and he started having the left shoulder pain about 5 months before he comes for the assessment. And 3 weeks prior to the assessment, he started to get numbness into the left forearm, into the left hand, and then he's also having weakness into the left hand as well. He believes that the pain got aggravated after he was lifting heavy equipment at work, but other than that, there was no falls, no slip, no actual mechanism of injury that he reported. So with that being said, with that short introduction, I want to ask, what would you ask next, or what would you ask in the history?
So this gentleman worked in film, and he was part of the crew that would set up and take down the sets. So often moving big equipment. He's like 5'6", probably weighs 140 pounds. Smoker, lives alone, doesn't look like he eats particularly well, and had enough seniority with the union that he felt comfortable that although it was his nature to get in there and get stuff moving, because a lot of times the young guys weren't is confident or we're moving too slowly. So often found himself doing work that perhaps someone of his age and seniority could have handed off to someone else.
Would
I could
anyone
try
ask? Yep.
a thought. So based on the brief history, there's some neurological symptoms, it appears. So if I'm taking a step back, I'd like to rule out some red flags from a neurological perspective. So I'd ask about lower body neurological symptoms and whether they're getting symptoms on the other side. And I've certainly seen when there's a lesion in the cervical region that they can have some bowel and bladder change. So asking sort of the red flags around neurological pathology here.
Absolutely. So there is no bilateral symptoms. Everything is happening on the left side. And pardon me for the terrible drawing. Most of the symptoms go between the shoulder blades, go down into the left forearm, goes into the fourth, fifth digit. Also, he is also experiencing some symptoms down the entire hand, but more severe symptoms into the fourth, fifth, but he does feel into the entire hand as well. In terms of lower extremity, no neurological symptoms into the lower extremity. In terms of the neck, he does not report any previous injury to the neck. But we will talk about that in the physical exam for sure. So there is a previous medical history of Crohn's disease and some arthritis, and he has some previous episodes of low back pain. He does have some mental health challenges, including depression. In terms of medications, he has tried Advil, prednisone for GI, and mirtazapine. Some of the aggravating factors include anything overhead, and also sleeping on the left side would cause him a lot of discomfort. And he explained that or described it as a knife stab into the mid-back whenever he sleeps onto the left side. He has tried hot shower and Advil, which only helped him temporarily, but nothing he noticed that actually helps resolve the issue. Any other questions would you guys ask? So we talked about medical history. There is some digestion issues, but that's not new. That's from the past. Some arthritis, he's 55, some low back pain and depression. And what other questions would you guys want to know or would want to ask?
Hi, Ash. Sorry, I don't know if I'm talking. One of the things like I would want to know about the nature of the pain as well. So is there a constant nature to it, or is it only with overhead activities, that type of thing? That would be something that maybe you've mentioned that, but
Yep, no, it's pretty constant. He can't really find a comfortable position. The left shoulder blade is pretty constant. It gets worse, although at its best, it's still present. So he's always having some level of discomfort. He can't sleep on the left. And in terms of weakness into the hands, he has a lot of weakness more into the fourth and fifth digits, and also lesser extent to the other three digits. But the pain is pretty constant. It fluctuates. He's never pain-free. Would anyone think it might be worthwhile talking about family history? If there was any, or his lifestyle, what he does in daily life? Maybe exercise, if he is actually doing any exercise, his diet and nutrition, is he eating enough? So this is someone who lives on his own. He's mostly eating from outside. And as Dr. Cruz mentioned, he is a chronic smoker. There is a family history of cardiac disease and also cancer in both parents who passed away in their 50s. Any other questions you guys want to ask before we move on to your differential diagnosis?
Well, I think there's a lot, certainly, with that additional information. I think with the positive cancer history, you would certainly want to uh, uh, at least rule out potentially a mass with questions around constitutional symptoms and infectious symptoms. I think, as far as I'm concerned on this presentation, I think it'd be important to distinguish on history, if you can, whether this is this if this is a nerve issue, whether it's coming from the spine or the periphery. So you could ask if the symptoms get worse when they bend their elbow or they put their elbow on a surface, and that may give you a little bit of clues whether this is coming from, if it is neurological, whether it's coming from the spine or the periphery.
Yeah, absolutely. And I think we briefly touched about that he doesn't really know what brings on the symptoms. The pain, he sort of comes and goes. He can't find a comfortable position. He doesn't really know what brings on the symptoms other than some overhead activities and also the sleeping on the left side. He can't really find a comfortable position. So it becomes challenging at first when someone comes in with a lot of pain, and then we're trying to do our due diligence and ask a lot of questions, but sometimes they might not be the good historians, and they want to just jump into the treatment. But in this case, he couldn't really recall any specific movement, whether he puts his forearm into the table, whether that would bring on symptoms or not. He was sort of frustrated because the symptoms have gone worse over the past 3 weeks, and it started in the past 5 months, and it kept getting worse.
One of the things that didn't come up at our first appointment, but did at the subsequent appointment, was that he felt that his hand was weak. And he wasn't left-handed, but he did do a lot of bilateral work using both hands equally, and had always felt it was strong. And he also said it was getting cold. And that would be like a toothache quality in terms of discomfort, but also physically, he'd put his hand on and it was colder than his other parts of his body. So there was a temperature difference that he was becoming aware of. So the weakness, which he felt was a subjective weakness and an objective, and that he was having trouble grasping things. His manual muscle testing for the lower extremity, like the upper extremity rather, in the hand, certainly did confirm some weakness, but we're going to get to that in a minute. So those were two other symptoms. So I think, John, just to sort of give you a sense, he had pain all the time, but certain activities made it worse. Okay.
Any preliminary differential thoughts?
So it's a bit atypical, but, I first thought that he is very stiff neck, which, we didn't talk about in the history, but I wondered if he had a cervical radic, or something in the plexus, a little bit lower down. I didn't think it was peripheral. I didn't think it was ulnar. I didn't think it was carpal tunnel. And the pain really started high up as well. So it was something that seemed to be central or close to central, and the exact nature of it to be determined.
Okay. Should we move on to the next doc? Okay. Awesome. So what physical or what tests or assessments would you guys perform for your physical exam? Any thoughts, ideas?
I would probably want to start with the neck and then kind of work my way down with like range of motion and strength.
Absolutely, absolutely. So the neck range of motion was limited, although if you do the orthopedic test on a roll in or out cervical radiculopathy, who would have some local pain, but nothing would actually be a true positive or would increase the pain down into the peripheral or into the upper extremity or into the hands. But range of motion would be limited, a lot of muscle tension in the neck. And yeah, anything else?
Did you do his reflexes? Sorry, Ash. Sorry.
No, it wasn't me. It was someone else. Sorry, go ahead. Any other thoughts? Would anyone think it might be worthwhile checking lower down, shoulder, elbow, wrist? Any tests?
I think further to John's point, you want to do bilateral upper extremities and then check distally too, whether or not there's any objective change in function and any change in reflexes, just like distally in the lower extremity as well, just to rule out whether or not there is something high in the cord. He certainly didn't endorse any by history, and there wasn't anything in my exam or your exam, and yours, of course, is much more detailed than mine. So, but yeah.
Okay. If you like, we can go to the next, unless you guys have any other suggestions. So this is very brief, just the explanation of what I usually look for in a physical exam. It's a lot more extent and more detail, but I usually like to start with observation and look any skin color changes, any swelling and redness, and range of motion, some orthopedic tests. I also like to start from the neck. If there is anything going down the extremities, I always like to start from higher up, check the joint above that actual joint and the joint below, do some orthopedic tests and a thorough neurological tests. What
Ash, would there be any special neuro tests you would do here? Any special ortho tests you would do here?
Oh yeah, absolutely. So if we start from the neck, simple orthopedic tests like Sperling's, I would even ask them to do Valsalva, sometimes even a slump test, and then going a bit more distally, more of a TOS orthopedic tests. So I do the big 3 TOS test, whether it's Atson's for the scalenes, Wrights, and Edens. And then going more to the brachial plexus, a little bit of a compression, going into the elbow, some pronator teres compression, cubital tunnel, supinator, and then upper nerve tension tests for sure. And then going down into the distal, into the wrist, examining the wrist. These are some, I think these are some of the primary ones. It depends on what I find. Sometimes if I find a lot of symptoms at the neck, then I'll spend more time at the neck, versus if I don't find something in the neck, I'll just go and try to figure out where the issue actually starts. So if I'm finding a lot of symptoms at the wrist, then I'll spend more time at the elbow going down from the wrist.
So in this patient, what was positive of your tests?
So Sperling was negative, but you know, with the cubital tunnel compression, for someone who is very slim and they have low muscle mass, if you palpate a lot of the cubital tunnel for someone who doesn't have a lot of muscle mass, you're going to find some positive symptoms. Compressing the carpal tunnel, again, it would find something, doesn't explain the weakness, but it would cause some numbness into the palm of the hand. Some of those can be false positive, and I made sure, you know, we check for the false positive. Atson's, that was also positive. So a lot of symptoms are happening from anywhere between the neck and the shoulder. And from the shoulder down, anything you find would be positive. So we know if from the shoulder down, things would be positive, then you have to look for something from the neck to the shoulder. And for the neurological tests, we would be doing motor strength for sure, the grip strength, the test for the anterior median nerve, wrist strength, light touch, temperature tests, because they're going to be in different spinal tracts, and the reflexes for sure. Surprisingly, this patient had symmetrical reflexes. They were intact. but lots of motor weakness, especially into the 4th, 5th digit, and some into the other proximal 3 fingers. Any
So
other
it's
tests?
something that's encompassing a number of nerve roots.
Yes.
We have a neck that's restricted. We have lots of other tests that bring on other sensory changes. So let's brainstorm on this differential. Is this a radiculopathy? Is this a cervical radic? Does anyone think it is, or not sure, or definitely not?
Did we observe any atrophy on exam?
A little bit in his hand.
Yes.
Was the stiff neck pain provoking, or is it just stiff?
Just locally, nothing down into the arms. Okay. So if you would like to add, just jump in. But what came to my mind right off the bat for someone who has pain for 5 months and it's getting worse, and he can't find a comfortable position. He is a 40 years old chronic smoker. There has been a history of cancer in both parents. Without looking at the physical exam, the first thing I want to rule out is sinister pathologies, Pancoast tumor, or any cardiovascular causes. Because one of the #1 risk factors for cancer is number of personal previous history of cancer or family history of cancer, and the environmental factors as well. So if we move on to the next slide, please. Unfortunately, right off the bat, I sent a letter to the family doctor asking for a referral to see Dr. Cruz, and also just ruling out other sinister pathologies. And all the credit goes to Dr. Cruz. I don't know where the patient would be without Dr. Cruz, because she really jumped in and provided all the resources and investigations, and it was very quick caught on. So the patient had a 6 by 5 centimeter mass into the left upper lobe apex of the brachial plexus and the mediastinum, and that was found with the MRI, and which was made as highly suspicious of Pancoast tumor. And sorry for going a lot over time, but I'll be happy to answer any questions.
I had a quick question. What MRI was ordered?
Of his neck and brachial plexus.
Okay.
Were any of the brachial plexus, like any of your upper limb tests, did any of them come back positive?
So with the peripheral, yes, because it would be compressing to brachial plexus. And if it's going from the apex of the lung, the first nerve roots that would be involved would be the C7, C8, that sort of distribution. That's when he had most of the weakness into the 4th, 5th digit. If it was coming something like a ganglionic cyst higher up from the cervical spine, it would be compressing more higher up into the C4, C5 type of brachial. So it would be a little bit of a different distribution. But yes, the test would come positive, but I thought that would definitely be a false positive, just based on the history.
Pretty much everything made his pain risk.
Yeah.
So
Barring history, like I know you're going to take history, that's the most important piece, but just from your clinical exam, did you see this person more than once before you referred, or did you refer right away? You had your spiny senses.
I referred this patient right away, but he's in a lot of pain. So somebody has to do palliative care until he gets the right diagnosis. And outside that, it's outside my scope. He just needs to follow with oncology. But right off the bat, like there should be no wait time. And I think, I don't know, Dr. Cruz, but I think he saw a family doctor first before coming to us. But
he had actually seen his family doctor and was complaining about his shoulder pain. neck and shoulder pain. The family doc thought it was neck and shoulder pain. And he had been trying to get back in to see him, and then saw Ash, who immediately, so Ash, you were the one that really, raised the red flag here. So kudos to you, my friend. And he was referred, the family doc said, okay, and I spoke with the family doc. I said, I'm really concerned. This is MRI. He's got a tumor. He needs to see oncology. Oh, right. So I'll arrange to get him in next week for some counseling. It's like, fuck, man. No. And I felt like, okay, now I'm mad and sad that I referred back to the family doc. I probably could have made the referral and it would have been a done deal. Right now, he's still waiting for staging and planning, poor man. So, and he's still in pain. He's on really high dose pregabalin. I've asked for him to be referred to pain service at Michael Garron. I'm not sure what's happening there. So that's our story. So the history wasn't very compelling, except there was lots of red flags and risk factors. And then the physical exam didn't make sense. It wasn't a simple presentation. And in the context of the history, it had to be something bad. The odds of it being something bad were much higher than the odds of it just being a complicated radiculopathy. So